We have a long program to cover, and in general, we enjoy to be on time whenever it is possible. So this is the next talk, and it has to do with the fetal posterior fossa anomalies, which represent a problem to us because the true malformations of the posterior fossa are far from being frequent. But from the point of view of sonography, they tend to overlap with the normal appearance. So we do receive a lot of patients that have a suspicion of having a posterior fossa anomaly, while in reality they have not. These are the learning objectives of this presentation, and by the end of this talk, you should be able to understand better what is the normal sonographic appearance of the fetal posterior fossa throughout gestation, as well as you should be able to better understand the different types of anomalies of the posterior fossa, their clinical implication, as well as the technique that you can use to differentiate them antenatally. Because most of all, this is a lecture that has to do with differential diagnosis of different entities. We start seeing fetuses quite early in gestation. In fact, we start seeing them when they are embryo. So it is important to have a perspective on how the anatomic structure develops throughout gestation. This is the first that we can see of the fetal brain, which is around 8-week gestation. And by 8-week gestation, the posterior fossa structures are dominated by the very large fourth ventricle, which is at this time in gestation the biggest of the primary cerebral vesicles. You can see it quite well as a big fluid-filled area, which seems to be on top of the head of the fetus. In reality, it is in the neck region because the embryo is flexed. You can also see the cerebellum at this time in gestation, and the cerebellum is very small, just these two very little dots right here on top of the cavity of the fourth ventricle, widely separated the one from the other. This is an embryologic specimen, and you can see quite well the cerebellum, which is that small solid mass just on top of the fourth ventricle. And you can see how huge is the fourth ventricle below. Now, as gestation progresses, the cerebellum grows from superior to inferior, and at the end, let's say by around mid-gestation, it has completely enfolded the cavity of the fourth ventricle. And you have the exit foramina of the fourth ventricle below the inferior portion of the cerebellum. That is the definitive configuration of the cerebellum. And in between 8 weeks and 20 weeks, you have different degrees of development. It has been recently pointed out in sonographic studies that there is an embryological remnant that was described as much as 100 years ago by Professor Blake, and that is why this embryological remnant goes under the name of Blake's pouch, which is sort of a small finger-like prolapse of the fourth ventricle, below the cerebellar vermis, just below the cerebellum. And this is something that with high-resolution sonography, you can see if you have good condition of visualization in virtually all cases around mid-gestation. It will appear like that. I wonder if you can see it well enough on the screen, but normally you can see septations into the posterior fossa, posterior to the cerebellum, in the cisterna magna. And if you look carefully, usually these septations include a cyst-like finding, which is presumably a Blake's pouch remaining after the development. It is almost never seen with any other diagnostic imaging tool, because ultrasound and mid-gestation with high-resolution probe has an exceedingly high level of resolution, in the level of about less than 1 millimeter. So if you happen to see a small cystic structure within an otherwise normal cisterna magna, of normal size, that is not a suspicion of abnormality. It is a completely normal finding. It is important for you to memorize this because we will go back to the Blake's pouch while we discuss the different abnormalities that can occur into this area. This is the fully developed cerebellum in an adult. It is made up by different portions, the hemispheres, that are joined in the middle by the vermis. And in between the brainstem and the vermis, you have the fourth ventricle. The fourth ventricle has a different appearance if you see it in the axial plane, where it is rectangular in shape, or if you see it in the sagittal plane. When you see it in the sagittal plane, it is like a triangle with the apex pointing posteriorly. Well, the apex is important because it is a specific landmark of the fourth ventricle. And neuroradiologists refer to the posterior apex of the fourth ventricle as to the fastigium, which is Latin and may be difficult to memorize. But you will need to know about that because we will go back to that later. Then the cerebellar vermis is made up by 3 different lobes. And these 3 lobes are divided by 2 fissures. That is the normal appearance. A normal cerebellar vermis is made up by 3 lobes, by a total of 11 lobules. We cannot see the lobules, but as you will see with ultrasound quite frequently, we are able to see the lobes and the fissure, and they are important landmarks. Now, that is the normal appearance in a sagittal view of the posterior fossa at 11 weeks gestation, and the fourth ventricle is still a big cavity in that area, and I would certainly recommend to you to listen to Rabbi Chawi's presentation, because this anatomic landmark carries enormous importance for the screening of neural tube defects early in gestation. And if you do an axial plane, you have the impression that the fourth ventricle is open posteriorly, is widely open, as if there was a communication between the cavity of the ventricle and the posterior cisterna magna. Well, in reality, there is no such thing as cisterna magna right now. It is just the fourth ventricle, which is very big and has not been completely covered by the developing cerebellum, which remains small. And we continue to have a very similar finding, usually up to mid-gestation. At 17-week gestation, as you can see, the cerebellar vermis is not fully developed, so it has not completely unfolded the fourth ventricle, and there is still a big cystic cavity below the cerebellar vermis. And as a consequence of that, if you do an axial plane, you have the impression that the fourth ventricle communicates posteriorly with the cisterna magna. Only after 20 weeks, in the majority of cases, let's say around 99.9% of the cases, the fourth ventricle has been completely unfolded by the cerebellar vermis, so let's say it is closed. You have to remember one important rule. If you scan a patient prior to 20 weeks, usually the fourth ventricle appears open. That is, you have the impression that there is a communication between the fourth ventricle and the posterior cisterna magna, which in reality is not the case. You have simply a very large fourth ventricle incompletely covered by the cerebellar vermis. These images that you are seeing in these 2 panels, here and there, they are completely normal. That is the norm prior to that gestational age. Usually, when we perform an examination of the fetal brain, we use axial section because they are easy to obtain and also they are very informative. And whenever you are performing a second trimester examination, we should always obtain at least this view, which is an axial section that was already described to you before by Boris Tuschek, and it runs along the basal ganglia, the cavum septipellucidi, encounters the cerebellum, and cuts across, as you can see, the most superior portion of the cerebellar vermis, above the level of the fourth ventricle. Now, if you do a dynamic sweep, you just move the transducer from the top of the head to the base of the skull, you encounter the superior portion of the cerebellar vermis, then you move down and you will encounter the fourth ventricle. You only have to try. It is relatively easy. Sometimes you are a bit bothered by the base of the skull, by the petrous ridges that create some shadowing artifact. But if you move around them, it is usually possible to see the cavity of the fourth ventricle and the inferior portion of the vermis separating the cavity from the cisterna magna. If you continue your movement of the transducer, then you will encounter the brainstem. So you will never find, under normal condition, an open fourth ventricle. That is a communication between the fourth ventricle and the cavity of the cisterna magna. This is a very important image. And if you want to add something in your baseline examination of the fetal brain that is not too time-consuming but is very informative, this scan is certainly important, because it demonstrates at the same time the fourth ventricle and the cisterna magna, and in between the fourth ventricle and the cisterna magna, a solid mass of tissue that tends to be more echogenic than the cerebellar hemisphere, which is the vermis. Now, this scan is important because only by using this scan sonographically you can be sure that the cerebellar vermis is present. I will try to demonstrate to you later on that there is no other possible way in the fetus that you can demonstrate that the cerebellar vermis is present than by using the scanning plane. Once again, solid tissue in between the fourth ventricle and the cisterna magna. And it is an easy scan to obtain. You just have to scan a little bit lower than where you usually measure the transverse cerebellar diameter. You can see that the landmarks of the hemisphere are almost the same. You can recognize the thalami, the third ventricle, and the cavum septi pellucidi. If you want to complete the study of the cerebellum and the posterior fossa, you need a much more difficult section, which is a sagittal section obtained along the antero-posterior axis of the fetal head, but that is a very difficult section to be obtained. So I would say that is certainly only for high-risk cases, the cases in which you have the suspicion that there is an abnormality. If you obtain this scanning view, however, it is important because you can evaluate the vermis in its complete shape, because only by seeing that in a sagittal plane you are able to tell that the vermis is intact or not. With magnetic resonance in later life, in adulthood, it is possible to visualize each of the lobules that are contained into the vermis. But in the fetus and even in the neonate, this is usually not possible. You do not have enough resolution. So you consider that the cerebellum is intact, that the vermis is intact, when you are able to see the main landmarks. Which are the main landmarks? Well, the fastigium of the fourth ventricle, we have already seen that before, that posterior apex of the triangle, and then the two main fissures. Because if you can see the two main fissures, that implies that there are three lobes. And the two main fissures are seen as indentation of the vermian mass, and they can be recognized with ultrasound, but it is very difficult, honestly. It is quite difficult, particularly in early gestation. Vaginal sonography is not very helpful when you are studying the posterior fossa, because if you are using vaginal sonography, it is never very well in focus. That is a problem that we have. In fact, it is difficult to obtain the median plane either transabdominal or transvaginal, so you have to use a combination of the two. You can scan through the anterior fontanelle, and that comes much better when you're performing transabdominal ultrasound, because you have good focalization of the cerebellum. And probably you get the best details if you are able to put your transducer at the level of the posterior fontanelle. And by using that approach, which is difficult to obtain, you probably get the best images, because you can visualize at the same time very well details of the cerebellar vermis, and also you can see very well the brainstem. We'll discuss later about the brainstem. The brainstem is important, and it is very difficult to visualize it with standard ultrasound. There is one potential pitfall in obtaining the sagittal plane, which is you never know for sure, you cannot never be completely sure that you are really seeing the vermis. Now, I can pretend to you that that is the vermis, but I cannot be sure, because in reality, I may be aligned along this plane, but I also may be aligned along a slightly offset plane, and in that case, I would see the cerebellar hemispheres. Now, the bottom line of this, the sagittal view is very helpful, but first of all, you must be sure that the vermis is present, and you can only be sure that the vermis is present by an axial scan. I hope that that is clear to you. Because if you are slightly off with your plane, you may look at a mass that seems normal, but in reality, that is not the vermis. It's just the cerebellar hemisphere, which is slightly off the scanning plane. That is why I think that there is a very important use for 3D ultrasound when you're making this evaluation, because it is very difficult to obtain the median plane. Even when you obtain the median plane, it is not so easy to be sure that you are exactly along the correct direction. But if you use three-dimensional ultrasound, that makes your life much easier. You just have this starting scanning plane, just a very simple axial plane in which you see the cerebellar vermis, and then you obtain a volume, and then from the volume you can obtain a virtual plane, like Boris has demonstrated to you, that usually allows very good visualization of the cerebellar vermis. Now, what is the advantage? The advantage is that when you are using three-dimensional ultrasound in the multiplanar mode, you exactly know where you're placing your section plane. Because this marker dot tells me that the section plane in this plane exactly corresponds to the cerebellar vermis. So this, as you can see, is an ideal representation of the posterior fossa, because I have simultaneously an axial plane that tells me that the vermis is present, and I can cut along the vermis and see how it appears in the sagittal plane. And usually, because I am using axial planes that usually allow quite good resolution, the definition of the fissure tends to be better than by using a direct approach. So for evaluating the posterior fossa, 3D ultrasound offers many advantages. You are more certain about the plane of section, and it is much easier to get the correct planes of section. The majority of patients that are now referred to my unit, and we see 2 to 3 every week, will usually enter into one of these two categories. Cases in which the cisterna magna is bigger than it is expected to be. We set an upper threshold at 10 millimeters. And there are many papers suggesting that if you have a size of cisterna magna that is greater than 10 millimeters, then the risk that there is an abnormality, different type of abnormality, is much increased. And therefore, these fetuses are at increased risk. It is pretty much the same as with mild ventriculomegaly. You have an increased collection of fluid in the cisterna magna, there may be something else. Or the cisterna magna is normal in size, but you have this finding that we will refer to as an open fourth ventricle, which looks like a cleft in between the cerebellum, connecting the fourth ventricle to the cavity of the cisterna magna, which again is completely normal prior to 20 weeks, but it is very rarely found after 20 weeks of gestation, and it has been suggested in many papers that this is the potential indication that there can be a malformation of the posterior fossa, such as the Dandy-Walker malformation. We'll go through these two different types of findings one at a time. But first of all, let me take a step back, because in the modern view, and it will probably change in 5 years from now, but in the modern view, all of these abnormalities are somehow related to an abnormal development of the Blake pouch. You remember that that is the normal appearance of the Blake pouch, that finger-like protrusion of the fourth ventricle below the cerebellum, below the cerebellar vermis. Sometimes it seems that this undergoes an expansion, resulting in an increased size of the cisterna magna. So in reality, it seems that it is not the cisterna magna which is bigger. It is the Blake's pouch that is big, only that we do not see anymore the borders of the Blake's pouch because the cisterna magna is being completely obliterated. And sometimes what happens is that this Blake's pouch is distended simultaneously with the fourth ventricle, and this pushes up the cerebellar vermis. It causes what the neuroradiologists say a cerebellar rotation, which is an upward displacement of the cerebellar vermis. Megacisterna magna. Well, the impression that in reality, when you have a large cisterna magna, it is not the cisterna magna which is big, but it is the Blake's pouch that is dilated, mainly comes from recent studies with ultrasound, in which when you have a very large cisterna magna, you do no longer see septation inside it, but you see something that really resembles a cystic collection with the walls of the cyst. This is megacisterna magna, which the obstetric definition says is a cisterna magna of more than 10 millimeters. Probably it does not overlap perfectly with the neuroradiological definition of megacisterna magna, because this is something that affects roughly 1% of all fetuses, 1 to 2%. 10 millimeters is the second standard deviation above the mean, so many fetuses will have this. In the vast majority of cases, these fetuses will not be defined postnatally as having a true megacisterna magna. We use this definition not because it identifies an anomaly, but because it identifies a risk factor. In fact, it has been found that the majority of fetuses, the vast majority of fetuses that have an isolated megacisterna magna do not have any problem at all. There is an issue whether this is associated with chromosomal aberration or not, but it seems that the only chromosomal aberration that is really found in this case is trisomy 18. So usually there are other malformations that you can detect with ultrasound. The main differential diagnosis of the megacisterna magna, should I wait a moment? The main differential diagnosis of megacisterna magna is a posterior fossa arachnoid cyst, which may be a problem because it may expand and it is not easy to operate in that area. Luckily, the posterior fossa arachnoid cysts are very rarely in the middle of the posterior fossa. They tend to be located asymmetrically. Therefore, you have a fluid collection into the cisterna magna, but you also have a mass effect that is pushing aside and distorting the cerebellum. So the differential diagnosis usually is quite easy. The implication is different because posterior fossa arachnoid cysts, they may grow in size and they may represent a neurosurgical problem. And now we go to one of the most common abnormal findings that I refer to our hospital, which is the open fourth ventricle, that we have defined, if you remember it well, as the presence of a seemingly communication between the cavity of the fourth ventricle and the cisterna magna. Now, this is a geometric problem mostly, because very frequently when we have this image, patients are told, oh, there is a defect in the vermis. Oh, there is the vermis which is missing. There's never been formed. Well, in reality, in the vast majority of cases, the vermis is present and it is perfectly intact. It is just geometry. This is a three-dimensional ultrasound, and I am using this to make this demonstration to you. It's coming on, hopefully. It should. Well, it may not, after all. Okay. Took some time. This is a three-dimensional reconstruction that has been obtained in a fetus that has an open fourth ventricle, and use as reference plane this sagittal view, where you can clearly see that the cerebellum is detached from the brainstem, and there is some fluid in between. Now I will move up and down. Okay, I'm moving up. And now look at what happened in the axial plane. I'm moving down now, and I am encountering the superior portion of the cerebellum. I can see the two cerebellar hemispheres. I can see the vermis in between. I continue to go down. And now I can see very well the important image, the fourth ventricle with the vermis in between the fourth ventricle and the cisterna magna, so I know that the vermis is present. And now I continue to go down. and I go in the lowest portion of that, where there is this fluid collection, and I can see that there is the impression that there is a communication. Now, finding a communication, a seemingly communication between the fourth ventricle and the cisterna magna does not imply that there is a defect in the vermis. In many cases, the vermis has only been pushed up. But the two hemispheres dangle on the two sides, and therefore you have the impression that there is a fluid-filled tract. In reality, this is no communication between the fourth ventricle and the cisterna magna. It is very simply a big Blake-Sporch cyst below that. And sometimes, with our resolution ultrasound, we even can see the walls of the cyst. An open fourth ventricle after 20 weeks should be regarded with suspicion. It may not be a malformation, very frequently just a normal variant, but it is a powerful indication for the presence of a malformation. If we consider our experience with this finding, fetuses always have been discovered later to have one of three conditions. Either a Blake-Sporch cyst. What is a Blake-Sporch cyst? It's just a very simple enlargement of the Blake-Sporch displacing the cerebellar vermis upward. Or they may have a true malformation, and that would be the Dandy-Walker malformation. Or they have something that is in between these two conditions, that once used to be referred to as Dandy-Walker variant, now the terminology has been abandoned. Now it is referred to as a vermian hypoplasia. So Dandy-Walker variant is not used anymore, is not in fashion. Now you have the Dandy-Walker malformation, the vermian hypoplasia, and the Blake-Sporch cyst. No more Dandy-Walker variant, and we will not refer to that. It is important because you will find several publications from later years discussing about Dandy-Walker malformation and Dandy-Walker variant. But that concept has been abandoned. Let's see each of these conditions and how they appear. This is Blake-Sporch cyst. Blake-Sporch cyst seen postnatally and antenatally. This is characterized by the open fourth ventricle. Usually the opening is very tight. And in the French literature, this has been referred as the buttock sign. You can immediately realize why. In the sagittal plane, you will see a cerebellar vermis that is completely normal, intact. In fact, you can see very well the fastigium, you can see the main fissure, it is completely intact, but it is slightly rotated upward. What you are seeing right here is the cerebellar tonsil, right there. And there is some fluid in between the brainstem and the cerebellar vermis, which is exactly the same that you can see antenatally with ultrasound. And this is exactly the same fetus, before and after. This is before, and this is after. And this is the sagittal plane, clearly demonstrated the fastigium of the fourth ventricle and the main lobes and so on and so forth. Now, this is Dandy-Walker malformation. It is similar, but in reality there are many important differences. Can you pick up what is the most important difference between these two entities? Now, I would say that there are mainly two findings that are important. The cisterna magna is much bigger. And you can see that it has become sort of a square. And the most important thing that tells you that the cisterna magna is big is that the brain has been pushed upward. The tentorium, which is the tent to the posterior fossa, where the straight sinus runs, instead of being down slanting, as it normally happens, as you can see, it is horizontal. In fact, this is the main criterion that is used by the neuroradiologist. They say that it is a Dandy-Walker malformation if there is, 1, superior rotation of the cerebellar vermis, 2, a superior dislocation of the tentorium. And to identify the tentorium, they look at the tortular aerophily, which is the sinus confluence. For neuroradiologists, that is very easily seen because it is a little square-shaped structure right there where the arrow is pointing. So these are the two main findings with Dandy-Walker malformation. upward rotation of the cerebellar vermis, and superior dislocation of the tortular aerophily. More about that. This is a comparison between a Blake-Sporch cyst and the Dandy-Walker malformation. The distinction is important because Blake-Sporch cysts usually have an excellent outcome. It's probably a normal variant. Dandy-Walker malformation is significantly associated with problems. And the point is that under normal condition, the tortular is implanted at the same level of the neck muscles. You know where the neck muscles are implanted? You can see that. I mean, if you touch the back of your head, you can clearly identify the position where the neck muscles are implanted. That is where the tortular should be. But when you have Dandy-Walker malformation, the neck muscles, you can see them, are implanted down there, and the tortular is several centimeters above. That is the main finding. Also, you can notice, while in the Blake-Sporch cyst, the tentorium is down slanting, with Dandy-Walker malformation, it has become horizontal. This is very easy to see, particularly with antenatal magnetic resonance. Ultrasound does not perform that well, but magnetic resonance performs very well because it allows you at the same time to see that little triangle there, which is the tortular. Can you see it? It's very clear. It's very neat. And the neck implantation. This is Blake-Sporch cyst, the tentorium down slanting, and this is Dandy-Walker malformation with the great superior rotation of the cerebellar vermis and the superior dislocation of the tortular aerophily. So diagnosis, as you can already see, depends a lot upon the medial plane, which is by far the most important one. You can make that assessment with ultrasound, but it is not so easy. Because with ultrasound, we have problems in visualizing the tortular aerophily, because we have a lot of shadowing in that area. And so we mainly rely on the direction of the tentorium. This is down slanting. This is almost horizontal. So this is most likely Dandy-Walker malformation, and that is Blake-Sporch cyst. It doesn't work as well as magnetic resonance, but if you do not have magnetic resonance, it is acceptable. The elevated insertion of the tentorium cerebellum and the displacement of the torcular aerophily is not a progressive phenomenon. It is always there from 20 weeks. It is not something that will occur late in gestation. We have followed serially several cases, and we always could document that finding as early as 18, 19 weeks gestation. So it is a very primary phenomenon, and it is reliable in early gestation. This is the same fetus that was examined at 22 weeks, 32 weeks, and 6 months. And as you can see, not much of a change. It is more or less always the same. This is Vermian hypoplasia, the condition that used to be referred to as Dandy-Walker variant. Neuroradiologists had introduced this concept because it looks a bit like Dandy-Walker malformation, but it is really not. The main difference is that there is not an expansion of the cisterna magna. So the tortular aerophily, it is in its normal position. And you make this diagnosis by demonstrating, as usual, that there is an open fourth ventricle. But when you go to the sagittal plane, you can see that that cerebellar vermis is much abnormal. More or less, it is half the size that it should have, and you cannot recognize any of the normal landmarks, the fastigium nor the fissure. Just a small bundle of tissue, intensely hyperechogenic. And that is the postnatal appearance. As you can see, that is the vermis, which is severely malformed, not only because it is small, but it is not even lobulated. The vermis is called like that, the worm, because it has lobulation. But usually when you have severe hypoplasia, you do not have any more lobulation, so you have just this small bundle of echogenic tissue. And as the vermis is so small, you have a very prominent opening to the fourth ventricle, which is the consequence of the open fourth ventricle sign. There was a cyst that was the expansion of the fourth ventricle, but that is a very fragile finding, and usually when you do an autopsy, it's completely disrupted. Now, Evaluation of the vermis is very important because it allows you to distinguish between the Blake's pouch and the vermin hypoplasia, and also identifies within the dandy walker a group that has a much greater risk. Evaluation of the integrity of the vermis is very difficult to make. Either you use ultrasound or use magnetic resonance is very difficult. And it mainly relies upon subjective finding. How do we do it? Well, it is difficult, as I told you, but if you can demonstrate the fastigium and the two fissures, then you are relatively sure that the vermis is intact, or at least that there is such a small degree of hypoplasia that is probably not going to matter really. Identify fastigium point and two fissure. That gives you the greatest level of assurance. Otherwise, you use a semi-subjective evaluation, because it is difficult to visualize the secondary fissure, but usually in the second trimester of gestation, the primary fissure is almost always well seen. And in general, it is one lobe above the primary fissure and two lobes below. So, more or less, twice as much cerebellum below the primary fissure as above. That is a semi-subjective assessment. Also, I would recommend very much, now there are biometric tables that are available in the literature, and you can measure the vermis. And of course, if as hypoplasia or partial agenesis occur in the posterior portion of the vermis, the most important diameter is the superinferior one. There are nomograms that you can use, and they can be quite helpful in reassuring you about that. In the majority of cases, it is pretty obvious. This is Blake's pouch cyst versus an hypoplastic vermis. And as you can see, this is a nice mass of cerebellar tissue with the indentation of the fastigium, one primary fissure, and that is just a little bundle of tissue, extremely small. So in many cases, it is pretty obvious since the beginning. And you can use magnetic resonance as well. We have not found that magnetic resonance in the second trimester is that helpful because we have very low resolution. This is around 24, 25-week gestation, and you can see it better. That is a normal vermis. You can see the fissure and the fastigium, but in that case, you can see something that looks like the primary fissure, but there is very little tissue below that. And in fact, this was vermin hypoplasia. Now, question, because it is difficult. Is this an hypoplastic vermis or not? I'm going to tell you that this patient was seen by several sonologists and neuroradiologists. One neuroradiologist claimed this to be an hypoplastic vermis. One sonologist said that it was an intact vermis, and the other one said he didn't know. How do you interpret that? Who believes it is hypoplastic? Raise your hand. Who believes it is intact? Who does not know? It is true. It is very difficult. But let me tell you, it did not make a lot of a difference because while we were debating and discussing, the karyotype came in and it was trisomy 13. And it was really, believe me, the only sonographic finding that was present. That is to tell you, the small message to take home. You may debate a lot about the anatomic appearance of these, but remember, there is a strong association between any of these and chromosomal aberration. So a detailed evaluation of the entire fetus and the karyotype are very important. We'll go back to this case in a moment. For this reason, because this has been reported recently in the literature, and we went back in retrospect and looked at that, and we found that it worked quite well. And it is a rather simple rule. These are axial plans, axial section, through the posterior fossa of three fetuses, one with the Blake's pouch cyst, one with the Dandy-Walker malformation, and the other one with vermin hypoplasia. All of these three images demonstrate a communication between the fourth ventricle and the cavity of the cisterna magna, and we agree on that. But is there a difference? Well, I think that there is an important difference that has been noted, and it is the shape of the communication, because in this case it is hourglass. Like in this case it is V-shaped or square-shaped. And remember this because it is important. Looking in retrospect at 20 cases plus a few more cases that we had, this always proved to be completely true. Whenever there was an hourglass configuration, the vermis was intact. And whenever it was V-shaped, it was abnormal. Now, I'm going to show you the previous image. Does it tell you anything? Well, in fact, it is V-shaped, which is the finding that carries the worst prognostic connotation. So we now include this in our algorithm. It is very important. If it is hourglass, if there is an hourglass configuration of the communication, usually that is a very good prognostic sign. If it is V-shaped, usually that implies either that the vermis is very small or that there is a significant degree of rotation, and both are not good prognostic factors. Again, it is very important to have the image in the sagittal plane, but that tells you a lot about the final prognostic significance of the single case. Differential diagnosis, these are the three entities. I'm not going to tell you that it's going to be easy to make the differentiation. I'm not going to tell you that you are going to be accurate 100% of the cases. But I think that at least the Blake-Spotch cyst and the Dandy-Walker malformation you can easily spot in the majority of cases. Again, the Blake-Spotch cyst is everything normal, but a slight upward rotation of the cerebellar vermis, usually less than 45 degrees. If the rotation is more than 45 degrees, you should be suspicious. Then the Walker malformation is significant upward rotation, usually more than 45 degrees, with an horizontal tentorium and a displacement of tortular aerophily. And vermian hypoplasia is a normal tortular, a normal cisterna magna, but a very small hypoplastic vermis, which is small by a biometric measurement and anatomically does not display all the landmarks that we have demonstrated to you. By far, in our own experience, and this is a multicentric study that we have done in Italy, megacisterna magna and Blake-Spotch cyst are the most common finding. They account for more than 50% of all cases. And that has been our experience on the outcome of these cases, and it is very limited because, of course, the follow-up will take much more, and there is the issue that whenever you see these cases, then it is difficult to obtain follow-up in all of them. But we were rather surprised to find that the most significant difference among all the groups was the frequency of associated malformations. That was quite rare with the Blake-Spotch cyst, and it was almost normal with the vermian hypoplasia and the Dandy-Walker malformation. When you take out the cases in which there were isolated malformation, all infants performed rather well. And the infants that did not perform well were those in which there were problems that we could not spot antenatally. Because, of course, there is always the possibility that there is a complex situation or a syndrome that you will not see antenatally. But in general, as you can see, Blake-Spotch cyst, they almost all do well. Megacisterna magna, they almost all do well. With the Dandy-Walker, usually they do poorly because they have other malformation, other problem, chromosomal aberration, ventriculomegaly, multiple anomalies. To summarize, when you are evaluating one of these cases, first of all, consider gestational age. An open fourth ventricle prior to 20-week gestation is normal, so you should refrain to make a diagnosis of abnormalcy unless there are other abnormal findings, such as a gigantic posterior fossa, gigantic cisterna magna, or ventriculomegaly. You should not even consider the possibility of an abnormality. An open fourth ventricle at 16 weeks is normal. You should not even tell the patient. Of course, that patient will have to be scanned at 20 weeks like any other. When you have one of those conditions, you should measure the cerebellum and the cisterna magna. If there is an open fourth ventricle, consider the shape of the opening, hourglass versus V-shaped. Hourglass is more frequently a normal variant. V-shaped is much more suspicious, and usually it is an abnormality. You should obtain either yourself if you have the ability, or you should contact your local expert, your local guru. You should obtain a mid-sagittal view. If you have 3D ultrasound, try to use it because it is very convenient. You should visualize the vermis, whether it is present or not. You should visualize the fourth ventricle, the vermian fissure, and the tortular. If you are not an expert about that, then you should obtain an expert opinion. You should always consider, however, other anomalies and consider karyotyping. We had several cases in a row of fetuses that only had an open fourth ventricle and they had chromosomal aberration, mostly including trisomy 13 and trisomy 21 as well. And there was nothing else on the sonogram that was abnormal. We are not going to solve all the problems, and there is in particular one anomaly that can be severe that affects the vermis, which is usually extremely difficult or impossible to diagnose antenatally, and that is Joubert syndrome. Joubert syndrome is a form of vermianagenesis or hypoplasia in which you have not a dilatation on the Blake's pouch. And as a consequence of that, the findings are very minimal. In this specific fetus, the only finding was the impression that there was an opening of the fourth ventricle, hourglass configuration, and when we went in the median plane, we were not sure. Because in the median plane, you are never sure. Is that a normal cerebellar vermis? In reality, you do not see any of the landmark, and the fourth ventricle does not have a clear fastigium. It is sort of round. And in fact, that was the appearance when the baby was born. And even if you are not expert in magnetic resonance, I'm sure that you can see that you have two hemispheres and no vermis in the middle. But of course, this is an anomaly that antenatally is extremely difficult to identify because the two hemispheres come together into the middle and it gives you the impression that the cerebellum is intact. And if you do a sagittal view, you have the impression that the cerebellar vermis is intact, but in reality, you are just seeing the two hemispheres that come into the middle. So this is a condition that usually we are not able to identify. Only if you have a proband, someone who had been already affected, and you document this finding, that has a very high positive predictive value. But otherwise, this is something that usually we are not able to predict. A few other anomalies that are rare and affect the cisterna magna and can be severe. Cerebellar hypoplasia. Cerebellar hypoplasia is not one single entity. It is a mixture of many different types of conditions that have in common a very small cerebellum. It is easy when you have this finding at 22 weeks because the cerebellum measures only half the normal value. But this was a case that had a completely normal scan at 20 weeks with a normal transverse cerebellar diameter and only later developed a cerebellar hypoplasia. Usually, most forms of cerebellar hypoplasia are progressive. In the second trimester, you do not see anything. In the third trimester, you see severe cerebellar hypoplasia. And it is a bunch of different genetic and non-genetic conditions that tend to have in common an extremely severe prognosis. That is the appearance. And as you can see, apart from the very small cerebellum that could be seen also on ultrasound, with magnetic resonance, you can see that there is an abnormality of the convolution, very thin cortex, and slightly enlarged ventricles, and a lot of subarachnoid space. And this fetus died immediately after birth. This is a case that was given to me by Rabbi Chawi, in which there is the concomitance, which is frequently seen between a very small cerebellum and a very small brainstem. The brainstem is important to evaluate in any of these cases. The combination of cerebellar hypoplasia and brainstem hypoplasia is a genetic condition which is called pontocerebellar hypoplasia. In reality, the majority of these cases will not display any abnormality prior to birth. There are just a few cases that will have these findings, usually only in the third trimester. And this is another malformation of the cerebellum that is, luckily it is very rare. It is called rhombencephalon synapsis. It is a very difficult word. It implies that the two cerebellar hemispheres are joined in the middle and there is no vermis in between. It is easy in this case because there is, it's frequently seen, concomitant severe cerebellar hypoplasia. So you see a large cisterna magna, a very small cerebellum, and immediately realize that there is a problem. But in other cases, and this is one image that was given to me by Gustavo Malinger, it may be very difficult to spot it, and the only clue to the diagnosis is that the cerebellar shape is triangular. But unless you are very expert, I guess that you are not going to find this abnormal, and you're going to miss this. And in fact, most of these cases are missed antenatally, or they are recognized because they have associated malformations. Obstetric management of posterior fossa anomalies. Well, the most important thing, really the clue, is a detailed examination of the brain. And the detailed examination of the brain should include multiplanar sonography. That is, you have to examine the brain of this fetus from many points of view, and the most important ones are the axial and the sagittal plane. You can do that by ultrasound, if you have the expertise, or you can do it magnetic resonance. But this has to be done. You cannot rely on standard transabdominal axial planes only. You really need to have a detailed neurosonographic or magnetic resonance evaluation of the brain. And also that should go with an evaluation of the entire anatomy, because very frequently these fetuses have other malformation. You should consider karyotyping. Our experience is limited, but even with isolated abnormal findings, even mild, we had chromosomal aberrations. So right now, we are offering karyotyping to each of these fetuses. And there is an issue that will probably be developed in the fetus of further genetic examination. Most likely, it is not the abnormality of the posterior fossa, the cause of the problem, is the combination with some genetic disease in most of these cases. And in fact, there are some reports that subtelomeric deletion can be useful in assessing the prognosis of these fetuses, and a lot of people are now using sophisticated molecular genetic techniques such as CGRK array, and maybe in the future that will help us in better discriminate among those infants that have abnormal findings but a normal outcome and the ones that will have an abnormal outcome. Serial exams are important because there can be a progression of this condition, particularly in the development of the ventriculomegaly, and you should counsel those patients on the basis of the specific finding. If you have isolated Blake's pouch cyst and cisterna magna, there is plenty of evidence, plenty of literature suggesting that the probability of a completely normal intellectual development is in excess of 90%. That is practically like the general population. Ultrasound or magnetic resonance? Well, there is a debate about that. There is no clear-cut evidence of which is the best technique. The results that are given by these techniques are very similar, and they largely depend upon the expertise of the operator. So it depends a lot on the organization. Of course, neuroradiologists have specific experience on cerebral anomalies, and that is very valuable. But if you are sending a patient to a place where they do magnetic resonance for the spine or for the knees, well, you cannot expect, in reality, an expert opinion. I think that the choice depends on how you are organized. In some places, you refer this patient to magnetic resonance. In some other places, you refer this patient for an expert sonographic examination. I don't think that there is a difference as long as the one who makes the final examination is an expert in that. In dubious cases, we have the tendency to use both because clearly there is synergy between the two techniques. Which are the key points that I would recommend for you to take home? That normal variants of Blake's pouch cyst and megacisterna magna are the most common finding. So when you have one of these conditions, you should consider the possibility that this is just a normal variant. Expert evaluation by neurosonography or magnetic resonance and careful search for associated anomalies are required in each of these cases. Prognosis is usually good without associated anomalies. There are other entities apart from the Blake's pouch cyst and the megacisterna magna, and these, as you have seen, may be difficult or impossible to diagnose antenatally. Thank you very much.